Hello everyone and welcome to Ovarian Cancer Australia's Information and Support webinar. My name is Vanessa Alford. I'm part of the support team at OCA. I'd like to begin by acknowledging the traditional owners of the land that we're on and pay my respect to elders past, present and emerging. This webinar will provide information about genetics and ovarian cancer, including the importance of genetic testing and the different types of testing. This webinar is interactive, so over the next hour you can ask questions to the presenters by using the dark blue hand icon at the top of your screen. Questions will be answered at the end of each speaker's presentation. Please note that presenters cannot address individual medical cases. If you have a particular question, please call the Ovarian Cancer Australia Information and Support line on 1300 660 334. For technical assistance during the webinar, please phone Redback Support on 1800 733 416. I'm extremely privileged to introduce our presenters to you. Our first speaker is Associate Professor Marion Harris, a medical oncologist and cancer geneticist who is the Director of the Familial Cancer Centre at Monash Health. Associate Professor Harris will talk about genetic testing for ovarian cancer. Our second speaker is Associate Professor Yoland Antill, a medical oncologist and cancer genetics specialist at Frankston Hospital, Royal Melbourne Hospital and Cabrini Health. Associate Professor Antill will talk about the use of genetic testing to guide therapy choice. We will then hear from Christine Christie, who sought genetic testing after discovering that her father carried the BRCA1 gene. Christine was also found to carry the BRCA1 gene and discovered she had early-stage ovarian cancer after having preventative surgery. She will talk about her experience and why genetic testing has been so important for her. So now I'd like to hand the microphone over to Associate Professor Marion Harris. Thanks, Marion.
Thanks, Vanessa. Well, without further introduction, I'll get going. And just some background to start. So genetics is a branch of biology that deals with genes and heredity, which is the passing of traits from parents to offspring. So a gene is a specific sequence of DNA that codes for a specific protein that has a role to play in the cell. And we inherit 2 copies of each gene that we have, one from each parent. And gene changes, in particular that predispose to epithelial ovarian cancer, can be inherited from the maternal or paternal branch of the family tree. I just wanted to highlight with this slide the difference between something that's genetic and something that's hereditary. So sometimes I hear people, particularly young people, say, the doctor said my cancer was genetic, when what they really meant is hereditary. So every single cancer cell has genetic alterations in its DNA. Only in a smaller percentage of cancers is there an alteration in the DNA of the egg or sperm that is transmitted from one generation to another that predisposes to an increased risk of a cancer type. So all cancers are genetic or have genetic changes, but only in a smaller proportion of cancers can there said to be a hereditary predisposition acting. Just wanted to touch on what is the cause of cancer. In short, we don't know, but a series of alterations or mutations in critical genes that control cell growth and division, or in genes that control repair of errors in DNA replication. So an alteration or change in the code in a gene results in a protein that is somehow altered. It may be absent, it may be shortened, and that protein doesn't work as it should. It doesn't do its job. As a consequence, cancer can develop. And we don't really know why. For example, a BRCA1 gene change causes cancers, particularly at some sites like breast ovary and not at other sites. Just touching again on sporadic versus hereditary cancer. So in most people, cancers are not hereditary. Genetic changes resulting in cancer occur due to random error, due to bad luck, so a DNA copying error. If we had to copy out the pages of a phone book each time, as a cell does to replicate, we would also make errors. So when we make errors, our body has systems to correct them. So most genetic errors are due to random bad luck, or these may be influenced by environmental exposures or lifestyle factors, the simplest one being cigarette smoking but also for female cancers, hormonal factors in particular. So these are sporadic cancers. We don't know specifically what's caused that gene change that caused that individual breast cancer to arise. These are sporadic cancers. But as I've already touched on, if there's an alteration or error in a cancer predisposition gene, then that gene change can pass down to different family members through generations. This isn't a hereditary cancer, but it's the predisposition to cancer is hereditary. Just touching for background the types of ovarian cancer. So when we speak of ovarian cancer, we're commonly referring to epithelial ovarian cancer, which is said to arise from epithelial cells on the surface of the ovary or fallopian tubes. These epithelial ovarian cancers are the main types associated with hereditary predispositions, and these make up about 90% of ovarian cancers. There are two other main types, germ cell tumours that arise from the egg cells of the ovary, which aren't typically hereditary, and sex cord tumours, which arise from the tumours like the connective tissue of the ovarian organ. And those latter two types, with a few exceptions, are generally not hereditary. Just a reminder that although we're refer to ovarian cancer, it's believed that most epithelial ovarian cancer starts in the fallopian tubes, in the fimbria at the ends of the fallopian tubes, and the cancer cells migrate along to the ovary or more rarely arise in the peritoneum. Just a reminder, the high-grade serous epithelial ovarian cancer is the most common type, a rarer type being a low-grade. Now, the difference in cells is how they look, how a pathologist would grade them under the microscope, how disorganised, the higher grade being more disorganised, and the lower grade more mimicking normal epithelial ovarian tissue. Mucinous, where mucin droplets are visible in the cell, a rarer type. Clear cell, big white cells, and endometrioid are less common types. So hereditary conditions associated with a risk of epithelial ovarian cancer, the main focus being BRCA1 and 2 breast ovarian cancer syndrome and Lynch syndrome. These are two highly penetrant conditions that confer an increased risk of ovarian cancer as well as other cancers. Then there's also PALB2, which is a relatively novel gene in the ovarian cancer space that we're routinely offering testing for now in familial cancer clinics, and we know that it's associated with about a 5% lifetime risk of ovarian cancer. Other genes, RAD51C and D, BRIP mutations, and then there's something that I'll just touch on, polygenic hereditary predisposition to ovarian cancer is something that's been unravelled. And then there still remains some people with a family history of ovarian cancer where the specific basis of it is not presently known. So going first to BRCA1 and 2, these are damage repair genes. They act as tumour suppressor genes. By maintaining the genetic order or correcting errors, they help to prevent cancer. The mutations or alterations in these genes, because we all have these genes, some people have an alteration that interferes with the protein produced and hence the function. They're inherited in an autosomal dominant fashion. And this just means that if you only inherit one altered copy, you have an increased risk of developing the condition. This contrasts with some conditions like cystic fibrosis, where an affected person needs to inherit an altered copy from both parents in order to develop the condition. So the idea is these people inherit one altered gene copy, and then a second hit occurs, knocking out their second gene copy, meaning that their damaged DNA isn't repaired, with resultant genetic instability, which is believed to predispose to cancer. And as I mentioned, for reasons not entirely clear of, these are mainly confined to the breast ovary in women, and also the prostate in men, as well as some other things like pancreas and melanoma. So it's thought about 1 in 400 individuals carry a BRCA1 or 2 mutation. In people with Ashkenazi Jewish ancestry, it's thought to be about 1 in 40, which is about 2.5%. There are so-called founder or common mutations in other people of different ancestries like Dutch and Indian. And we think that approximately up to 20% of all epithelial ovarian cancer diagnoses, there's a BRCA1 or 2 gene change. So BRCA1 or 2 mutations explain up to 85% of epithelial ovarian cancer in women who have a family history. So if there's 2 women in a family with ovarian cancer, the odds are that it's a BRCA1 or 2 gene change. So BRCA1s and 2 are both associated with up to a 70% lifetime risk of breast cancer. For ovarian cancer for BRCA1, it's thought to be a 50% lifetime risk. That's classically high-grade serous. And for BRCA2, the risk 10 to 20% lifetime risk. As I said, it's usually high-grade serous, but it can be endometrioid or clear cell. We don't typically associate low-grade serous ovarian cancer, borderline tumours or mucinous epithelial ovarian cancers with BRCA1 or 2 mutations. So these cancer types are not usually offered BRCA1 or 2 gene testing. Some of the indicators we look for a personal or family history of breast cancer in close relatives, particularly young age or triple negative. We look for other people who've had high-grade serous epithelial ovarian cancer, ancestry, high-grade prostate cancer, as determined by the Gleason score in the family, can be an indicator. Pancreatic cancer in the family. The age of the person, so BRCA mutations are less common in women diagnosed under 30 or over 70, so more typically in that middle range. And as I said, more typically serous, but can also be an endometrioid and clear cell. So all invasive epithelial adenocarcinomas of the ovary that are not mucinous and are not borderline are generally considered eligible for BRCA testing. Some units apply an upper age limit of 65 or 70, but not all. Yoland's going to talk about the therapeutic aspects, how having a mutation affects someone's treatment, but just so touching on the effect for relatives. So where a BRCA gene change is identified, there can be predictive testing for unaffected relatives, giving them the opportunity to undertake preventive actions, whether it's breast cancer screening, breast surgery, and to consider bilateral salpingo oophorectomy by age 40 for BRCA1 carriers and by 45 for BRCA2. It's thought that a small risk of primary peritoneal cancer remains. Then for men, there can be PSA screening. So some figures, I've said it can be up to 20% risk of having a BRCA mutation. If someone has an epithelial ovarian cancer, depending on the age and the exact type, it can be sort of 13 to 16%, primary peritoneal cancer, say 15%, fallopian tube 20%, a lower chance of a mutation if there's a clear cell or endometrioid cancer. And for people who are over 65, the risk of a mutation being identified is lower. So instead of 15 to 20, it's more like 8%. So just moving on from BRCA1 or 2 to Lynch syndrome, which is a hereditary cancer predisposition that explains about a smaller proportion than BRCA of hereditary ovarian cancer. So this is due to a mutation in one of a number of so-called mismatch repair genes that are also involved in DNA repair and also have autosomal dominant inheritance, meaning you just need to inherit one altered copy to have that predisposition for cancer. So the typical cancers for this condition are more colorectal endometrial cancer, and ovarian cancer is a less frequently observed. There's often a multi-generational history of cancer, but not always. The types of ovarian tumours are different. More typically, these are endometrioid, clear cell. They can be mucinous or borderline. They're less likely to be serous tumours. They can occur but are uncommon. And classically, epithelial ovarian cancer in Lynch syndrome occurs at a younger age. And pathologists can screen for Lynch syndrome in people with ovarian cancer by doing a special stain, although in isolation, it's not routine to always do this. So once again, Yoland's going to touch on the therapy options, but in terms of someone who's found to have these gene changes and for their family members, they may need to consider screening for other cancers like bowel cancer. And also their relatives, if they have the same gene change, similar thing, might need to consider preventive salpingo-oophorectomy or colonoscopies. So just touching base on some of the more rarer things. So I mentioned, so many of these proteins work together to interact with BRCA1 and 2. So PALB2, which could also be called BRCA3, is partner and localizer of BRCA2. So it works in together with BRCA2, hence it causes a similar issue of an increased risk of breast and ovarian cancer. RAD51C and D do the same. There's another gene that's called BRIP, and these are all three, all inherited in the autosomal dominant fashion. The lifetime risk of ovarian cancer is what we call low penetrance, meaning there's only a 5 to 10% risk. In contrast, BRCA1 is said to be a high penetrance, where if you have the gene change, you can have up to a 40% lifetime risk. They all three are associated with some increase in breast cancer risk, and there are preventive options for family members that carry the same gene change to have a salpingo-oophorectomy, albeit at a bit of a later age. Just touching on these, CHEK2 and ATM are the names of another couple of genes that are particularly associated with breast cancer risk. And the exact increase in ovarian cancer risk is unclear. As I mentioned before, there's a group that remain unknown. The genetic basis and mechanism of inheritance is unknown. I'm just going to touch base here on something that's called polygenic risk. So in contrast with BRCA1 or 2, it's what we call a monogenic or a single gene risk. There's the emerging ideas for a number of cancer types, particularly prostate and breast, the idea of these SNPs, which are single nucleotide polymorphism, or sites in DNA where variation is common. So we think of inheriting these relevant SNPs like a hand of cards, and each individual SNP increases or decreases the risk of a disease, which in this case we'd be talking about ovarian cancer, but these have also been studied in prostate cancer or cardiovascular disease. Each SNP increases or decreases your risk of disease by a small degree, but it's the combined effect, it's like a hand of cards, of the individual's multiple relevant SNPs relevant for ovarian cancer that determine their polygenic risk for that outcome. So some people will inherit a low-risk combination, a low-risk hand of cards, and some will inherit a high-risk combination. Most people will inherit a medium risk. So this is increasingly being understood and studied in a research setting, and may be part of our genetic testing for people with ovarian cancer in the near future. Yoland's going to touch on this, so I'm just going to introduce it. So when we talk about germline genetic testing, we're talking about blood or skin testing, and it's the genetic makeup of those cells are thought to be representative of all the cells in the body, which will include the egg cells in the ovary or the sperm cells in the testis. In contrast, somatic genetic testing is testing of tumour tissue. And while typically therapies are for germline BRCA mutations, testing and finding somatic or tumour alone BRCA mutations can also enable access to therapies like PARP. And just a reminder, so a mutation is an alteration or a change in the DNA. Pathogenic is disease-causing alteration, and a variant of uncertain significance means it's uncertain if the genetic change has any impact on the functional health of the gene product or protein. So we all carry alterations in our DNA, and many of them are not significant, but some of them are. And we all carry a lot of variants, and it is quite a process and a science trying to work out if these genetic changes are pathogenic or if they are variants of uncertain or indeed of no significance. I just wanted to say this is a typical ovarian cancer panel that we would request pretty much throughout Victoria for most people with ovarian cancer. So as you can see, it's currently a 12-gene panel, including BRCA1 and 2. These 5 all relate to testing the different genes involved in causing Lynch syndrome. P53 is thrown in. It's more typically a breast sarcoma, but it can sometimes cause cases of ovarian cancer. PALB2, I mentioned, a 5 to 10% risk, same with BRIP and RAD51C and D. So this is pretty much a standard panel. And this is my last slide, but just going through, this is just one series from a few years ago that reported over 4,000 women who had a germline test, and they were tested for 32 genes. And this is just an example where 13% of the group had a disease-causing variant or pathogenic mutation detected, and that was a bit low. They were perhaps thinking more, might have been 16 or 20%. 25% had one of these variants of uncertain significance, and these generally need to be followed up. And over a period of time, some of these will be downgraded to be just variants or nothing significant. Others of them will be upgraded and determined that it's actually now disease-causing. And over half have a negative, or what we call an uninformative result. Out of this group, about 20% had a family history of ovarian cancer, and about 13% had a prior history of breast cancer. Of the mutations found, as we said, the biggest player, BRCA1 and 2, 54%. A little bit surprising for me, so this CHEK2 that I mentioned, 10%. Then the mismatch repair genes causing Lynch syndrome at 9%. And then the other genes that you can see, so that ATM, or typically a moderate breast cancer gene, BRIT for ovary, RAD51C and D making up a few percent. So look, with that, I'll conclude there and hand back to Vanessa. Thank you.
Thank you very much, Marion, for that extremely informative presentation. We just have a couple of questions for you. One is, if someone does have ovarian cancer and they have not undergone genetic testing, how do they go about getting it?
So it would probably be good to touch base with their treating doctor to just clarify, have they had genetic testing? But generally they need to sign a specific consent form. So if the person doesn't recall doing that, they probably haven't had it. They can always ring, so testing with their clinician, but they can also always ring a familial cancer clinic in whichever state of Australia they are to make an inquiry. But generally they would need a referral from their GP to discuss having genetic testing if they've not already had it. So Googling familial cancer clinic in their state would be the way to start and getting a referral.
And what is the cost involved?
So generally there's a Medicare item number, so there are a few restrictions, but generally most people with epithelial ovarian cancer, particularly high grade, are automatically eligible for genetic testing so that it is covered. It's basically free, covered by their Medicare cover, so there's no actual charge. If someone wants to have testing outside guidelines, for example, if they had a mucinous ovarian cancer, or if they were unaffected but had a family history, they would have to pay for it. And so depending on the panel, it might be up to about $500, but that is a lot cheaper than it used to be. With all breakthroughs in genetic testing, can be done much faster and more cheaply. So in the past, it would have been a few thousand. Now it might be about $400 or $500. But for most people, it is free.
Great. That's great to hear. Thanks, Marion. There's just one more question. Is HRD testing going to be available in Australia soon? It wasn't an option when I originally had my testing done. This is from one of the participants.
So at the minute, that's very topical. So I understand that there was sort of a patent held by a company in the States. So I know some people were paying for their samples, tumour samples and blood samples to go over to the States to get a report back to then determine, whether they should look at, self-funding, one of the PARP inhibitors. I believe there are moves afoot to make a different type of HRD testing available in Australia. So at my own centre, I believe deals are being done to enable something to be available in Australia. But I suppose if someone gets an HRD test, you sort of need a therapy that's available. So at the minute, the Australian guidelines say you need to have a BRCA mutation. So if you have an HRD test that's positive, but you don't have a cleared germline or somatic mutation, it might be tricky to get a Medicare-funded subsidised therapy, but of course people can fund it themselves. So look, in short, I hope that it might be around the corner. I don't think it's going to be in the next month, but I would certainly hope in the next 6 to 12 months. So watch this space. And I don't know if Yoland had any particular comment to add there.
We might move on to Yoland, so she can probably answer that as she presents. Just before I do bring Yoland to the microphone, just a reminder, if you'd like to ask a question, just use the dark blue hand icon at the top of your screen. So I'd now like to hand over to Associate Professor Yoland Antill. Thanks, Yoland.
Thanks, Vanessa, and thank you to Marion. It's always nice going second because usually the speakers prior to me will set the stage beautifully for where I'm going to move into. So I'm going to talk tonight about how we might use genetics to guide treatments. Ooh. Providing I can work the slides. So Marion has already described beautifully the difference between familial and tumour mutations. So the familial or hereditary mutations are ones found in the egg or the sperm that are passed by hereditary to the offspring, and they're present in all cells. And this results in heritable conditions such as an increased risk for cancer, in particular ovarian cancer we're focusing on here tonight. Somatic or tumour mutations are present within the tumour cells themselves. They can reproduce the abnormality within the cells within the tumour, but they are not heritable from generation to generation. So non-hereditary genetic changes occur in ovarian cancers as they do in all cancers. These genetic changes can be what we call somatic, so they're acquired changes within the genetic code of tumour cells, and it impacts that normal function of the gene. When someone talks about something being clonal, it means that as the cells reproduce within the tumour, as the tumour cells grow and divide to make new cells, those same mutations are present. But generally, as a tumour has been there for a longer period of time, and the more generations of cells or the more cells that are produced within the tumour, the more mutations are acquired within the tumour itself. A tumour can also have a gene that's silenced. This is called methylation. When an active chemical process starts or impacts the beginning part of the gene to stop it being read from beginning to end. It's like closing the book on the start of your recipe. It stops that gene from functioning normally. And again, within the tumour, methylation impact on one cell can occur in the generation of cells below that. Methylation can be hereditary, but it is a very, very rare condition. And then we're also going to focus on this concept called homologous recombination deficiency, or HRD. So hereditary ovarian or ovarian-like cancers, so just to remind you, as Marion has said, when we're talking about ovarian cancers, we're including tumours that have arisen from the ovary, tumours that have arisen from the fallopian tubes, or tumours that have arisen from the blanket covering of the abdominal cavity known as the peritoneum or primary peritoneal cancer. So hereditary ovarian cancers are associated with genes that Marion has already run through. The most common of the genes associated with hereditary ovarian cancer are BRCA1 and BRCA2. There are other genes that are involved in double-strand break repair or homologous recombination repair, and they're those ones known as RAD51C and D, BRIP, potentially ATM and CHEK2. We then also have those mismatch repair genes, the Lynch genes, that make up around 10 to 15% of hereditary ovarian cancer. And as Marion has described, the Lee-Fraumeni syndrome, or a very rare condition associated usually with very young onset ovarian cancer in a gene known as TP53. The Walsh paper on the side was published a number of years ago and demonstrates, again, a similar spread of the genes that we've described. And there are a large number of studies now that have been published looking at nationwide or multinational collections of women who've experienced ovarian or ovarian-like cancer, and the breakdown of the genes contributing to ovarian cancer risk is very similar. This includes the Australian Ovarian Cancer Study. So homologous recombination recombination is an important pathway of the way repair is enabled when damage occurs in that genetic code. So DNA, the chemical, remember, that tells our cells how to work and behave, is constantly being damaged and repairs itself within our body to create a perfect copy of that genetic code in the generations of cells beyond that first cell. So when DNA is repaired, the process is called homologous recombination. Homologous recombination deficiency is when the body is unable to repair those double-strand breaks. And it means that the cancer cells have a harder time repairing themselves, and people whose tumours are associated with what we call homologous recombination deficiency may have a greater sensitivity to certain treatment types. And we'll go into that in the next couple of slides. Originally, it was felt that BRCA1 and BRCA2 were the only genes associated with this condition known as homologous recombination deficiency. But we know now that there are other genes associated within this pathway. So homologous recombination deficiency is a state associated with an alteration in one of the genes that is associated with DNA double-strand repair. So this can either occur because of a hereditary change in one of those genes, or if the change has occurred in that tumour, in those tumour cells themselves, either as a somatic change or as silenced by methylation. We know that BRCA1 and BRCA2 associated ovarian or ovarian-like cancers have a greater likelihood of response to carboplatin-based chemotherapy. We also know that BRCA1 and BRCA2 related ovarian cancers have an ongoing or a greater likelihood of ongoing response to platinum therapies. So platinum would be the first-line choice in the early ovarian cancer setting aimed at cure. But if an ovarian cancer relapses, particularly for those BRCA1 and 2 carriers, we would offer generally platinum as second, but often those tumours respond again and again and again to platinum-based chemotherapies before resistance would occur. We know that, in fact, homologous recombination deficient tumours are more likely also to respond to platinum-based therapies and will perhaps respond again in that relapse setting and perhaps have prolonged platinum sensitivity compared to those homologous recombination proficient tumours. We also know from the SOLO-1 and the SOLO-2 trials that once chemotherapy has been given, if we maintain the effect of that platinum-based therapy with a PARP inhibitor known as olaparib, that it reduces the risks of recurrence or relapse again of that ovarian cancer. So these graphs that we've got here are what we know as Kaplan-Meier curves. You don't need to remember the names of that. It was a clever person who designed the way of statistically analysing whether a treatment responds or does not respond to a tumour. So if we look at these two curves, every time the line drops down, it means that a tumour is no longer responding to the treatment. In this case, the treatment is olaparib. So this was a trial looking at first-line maintenance therapy. So this means that women have been diagnosed with ovarian cancer and they've received treatment for the first time. And on the completion of their chemotherapy, they were randomised to receive either olaparib or a dummy drug. And you can see very clearly that even within 3 months, these curves start to separate. And there are fewer women whose tumours relapsed who received olaparib compared to those women who received a dummy drug. Similarly, in the relapse setting, so these are women whose cancers unfortunately have returned, there was a study that again looked at the comparison of olaparib with a dummy drug, and again, following chemotherapy with platinum, you can see that within a few months that the women who were receiving the olaparib had a lower chance of their tumours relapsing again than those women who received the dummy drug. A very wise person once told me that if you can drive a pencil between the lines of the curve on these studies, then it means you've got a treatment that works well. So we know now that in Australia, if you are a carrier of a BRCA1 or a BRCA2 mutation, either within your tumour, so a somatic mutation, or as a hereditary change, you are eligible to receive olaparib following your first-line treatment. And if you continue to have a tumour that is sensitive to platinum in the relapsed setting, if your cancer returns, then you would be offered olaparib as maintenance therapy at relapse. So more recently, and particularly as we know now that BRCA1 and BRCA2 are not the only genes that contribute to this condition known as homologous recombination deficiency, the PRIMA trial looking at niraparib maintenance, and again, there are two trials looking at niraparib, both in the relapsed setting and in the first-line setting, and I've just looked at or put up the picture here of these curves for the first-line setting. You can see that in all women with homologous recombination deficient tumours, and about half of the total number of patients had homologous recombination deficient tumours, you could see a very significant difference again with fewer tumours relapsing if they were given niraparib versus those who received the dummy drug. Again, these curves start to separate out at around about that 3-month time period. If we look over here, though, at this particular graph, you can see that even the tumours that were homologous recombination proficient, so this dotted line here represents the line that suggests whether a tumour group will respond or not respond. And if you're on the left-hand side of the curve, you're a responder. If you're on the right-hand side of the curve, you're a non-responder. If you cross the line, then it's not really a statistically significant finding, but you can see that the homologous recombination proficient tumour group, albeit a small group, they still received a benefit from niraparib maintenance therapy. So currently, we know that women can receive niraparib access via an access program, but it's not all women with high-grade epithelial ovarian cancer, and that reflects the women who were recruited onto the PRIMA study. So women who had high grade, and that represents grade 2 or grade 3, epithelial serous ovarian cancer and epithelial endometrioid cancer, regardless of their BRCA status, are eligible to receive niraparib via the access program. That means at no cost to that patient. I have put here the outcomes of some of the side effects that can occur when you are on either olaparib or niraparib. And we know that there are differences in side effects between olaparib and niraparib, and certainly compared to a dummy drug. There are side effects that we would expect with both olaparib and niraparib. particularly differentiating a risk of blood pressure, increased blood pressure with niraparib, and a greater likelihood of things like thrombocytopenia and nausea with and fatigue with niraparib compared to olaparib. So while these medications are available for use, they can cause side effects, and you may need a dose reduction if you're receiving niraparib. So it's important to tell your medical oncologist if you are experiencing side effects if you are on maintenance therapy, because we know that a significant proportion of patients, both on the SOLO-1 and SOLO-2 trials, so they are the olaparib PARP inhibitor trials for BRCA1 and BRCA2 carriers, and an even greater proportion of patients on the PRIMA and NOVA studies looking at niraparib in the relapsed and first-line setting, experienced side effects that needed them to reduce the dose of the medication, but patients' tumours still responded to those lower doses. So don't ever be shy or keep to yourself any side effects that you might be experiencing, because a dose reduction does not mean a lower risk of responding to the therapy. I'm going to move now to the ovarian cancers that might be associated with mismatch repair deficiency or the Lynch syndrome genes. So in recent times, we know that the expansion of immune therapy with treatments known as immune checkpoint inhibitor therapy has expanded and is of particular interest in cancers that relate to mismatch repair deficiency. In general, these are cancers that have a really strong interest or a tie-in to the body's immune system. And we know that using single-agent immune therapies has a very high likelihood of response to immune checkpoint inhibitors if, in fact, they have this condition or state known as mismatch repair deficiency. In ovarian cancers, the vast majority of ovarian cancers associated with mismatch repair deficiency are of endometrioid histology. They are often associated with endometriosis, but may in fact represent the small proportion of ovarian cancers that occur in very young women. So if we have an endometrioid, in particular ovarian cancer, we would often ask our pathologist to do this preliminary test that Marion described, looking to see if mismatch repair deficiency might be implied in the setting of that ovarian cancer. Just like BRCA1 and BRCA2, mismatch repair mutations can occur either as hereditary change or within the tumour themselves. But response to immune checkpoint inhibitor therapy can occur either because of that hereditary change or because of the changes within the tumour cells themselves. So even though, as Marion said, the mismatch repair genes may be part of an ovarian cancer gene test, if an ovarian cancer relapses, it would be important to consider that mismatch repair expression testing on the tumour to understand whether immune checkpoint inhibitor therapy may be an important treatment to consider in the setting of that relapsed ovarian cancer. So testing for hereditary ovarian cancer is still important, even though many more women can now access PARP inhibitors in the maintenance setting, as if a genetic alteration or what is known as a pathogenic variant is identified, the results individuals may, of course, impact the management for long-term ovarian cancer via access to PARP inhibitors, in particular olaparib in comparison to niraparib. But remembering now, if we go back to our slide of the SOLO-1 trials, nearly 50% of our patients who were diagnosed with ovarian cancer in the setting of BRCA1 and 2 are now surviving their ovarian cancer diagnosis. So while in the past we hadn't really focused on the other cancer risks that might be associated with that particular gene, for those women, managing those other cancer risks are now very important. Of course, managing and testing for other family members is just as important if a hereditary change is identified. Gene testing, as Marion described, is largely a funded option if the chance of an abnormal ovarian cancer gene is greater than 10%. And this occurs in most epithelial ovarian cancers. Testing can either be done through a traditional family cancer centre referral or through your own medical oncology or your gynecology oncologist through a process known as mainstream testing. Remembering that the risks of other cancer types with some of these genes is also increased. And Marion's touched on this. So if we look at the BRCA1 and BRCA2, we can see that breast cancer risk is significantly increased, as it is for PALB2. If we look at Lynch syndrome, we know that yes, ovarian cancer is greatest risk, but so too is a bowel cancer risk. Ordinarily, if someone is diagnosed with ovarian cancer, the original surgery would involve removal of the uterus as part of their surgery for their ovarian cancer. So the risk for uterine cancer that would be associated with Lynch syndrome is actually removed as a result of their original surgery. There are smaller risks for other cancers, in particular for males, including prostate cancer and pancreatic cancer. And I haven't mentioned some of the more rare genes like ATM, RAD51C and RAD51D and BRIP, but certainly as more is known about the genes that are associated with ovarian cancer risk, and more is known about the other cancer types that may be associated with the more recently identified genes. So in summary, genetic changes, either hereditary or within the tumour, can predict increased response to certain types of therapies. BRCA1 and BRCA2 have prolonged and repeated responses to platinum therapy and derive benefit from the use of olaparib maintenance. In particular, HRD-related tumours have increased sensitivity to PARP inhibition and have access now in Australia to niraparib, and mismatch repair deficient tumours may be associated with an increased likelihood of response to immune checkpoint inhibitor therapies. Testing for these hereditary genes is still important to understand the potential risks for other cancers in the individual, but also understanding whether other family members will also be at increased risk of cancers and what they might do to prevent or manage that cancer risk. Thanks, Vanessa. Back to you.
Wow, thank you so much, Yoland. So much valuable information in that presentation. We've had a lot of questions come through, so I do apologise if we don't have your question answered. I am conscious of time, so we'll just go with two questions. The first one is, can ovarian cancer skip a generation? My mother died of ovarian cancer in 1967, and I have two daughters. She says I don't have the BRCA gene.
That's a really interesting question. Oh, did you want me to answer that, or did you want
please.
Marion to answer that? Okay, I'll answer that. So the risk of a cancer is not 100% for these genes. And so particularly if a genetic change is being passed from a father or through a father to a daughter, it can seemingly miss a generation. The risk for ovarian cancer for BRCA2 in particular can really vary from family to family, from around 10% risk to as high as 70 or even 80% risk. So it can seemingly miss a generation, but the actual genetic change is passed from mother to daughter or father to daughter or mother to son or father to son, and then generation on from that. So the actual genetic change doesn't skip a generation, but the risk for cancers is different from individual to individual.
Thank you. And one last question. What is the difference between olaparib and niraparib? I don't understand why one is used instead of the other.
So they are different. They're both PARP inhibitors. Niraparib is thought to have greater potency, so it's a more complete blockade of the way PARP works in homologous recombination repair. And it's possibly also why there are more side effects associated with niraparib use than olaparib. If you are a BRCA1 or a BRCA2 carrier, or the tumour has BRCA1 or BRCA2 alteration, we know that olaparib is an effective way of maintaining the effect of the original cancer. But we don't have the same confidence that olaparib will work in all HRD and particularly a homologous recombination proficient cancers. So at the moment in Australia, unless you have a BRCA1 or a BRCA2 gene change, either hereditary or within the tumour, then olaparib is not available for use for maintaining the effect of your chemotherapy, but recently available is now niraparib.
Great, thank you for clearing that up. Thank you again very much, Yoland, for joining us on this webinar. We will now move to our final speaker, Christine Christie. Thanks, Christine, over to you.
Thank you, Vanessa. Hello, everyone, and welcome. As Vanessa has said, my name is Christine, and I have been invited along this evening to share with you our family's experiences with genetic testing. I think that it is reasonable to say that I came to ovarian cancer from a slightly different angle to many women, and I like to think that our family's story might be a cautionary tale for other people out there. I feel that it demonstrates the value in having the courage to undergo genetic testing if there is any suggestion that you or your family might be at risk of carrying a genetic mutation. I also think that it highlights the value in understanding the risks associated with your genetic status, and also the value in taking that knowledge, learning about it, and then making considered choices that sit well with you. To understand why genetic testing has been important for me, we have to look back over a number of generations at the history of cancer in my family. I always knew growing up during the 70s and 80s that my grandmother, Dad's mum, had died of breast cancer. My aunt, Dad's sister, had died of ovarian cancer, and another of Dad's sisters had breast cancer. My dad was just 13 when his mother died. His sister, with ovarian cancer, died when she was 47, and his sister with breast cancer died from the effects of her treatments in her mid-50s. As an adult, I have also learned that my great-grandmother died from breast cancer too. For some inexplicable reason, I have always felt that this family history of cancer was important to me. I do not understand why, it just was. It is not a topic that was talked about frequently in our family, and it never interfered with my life in any way. It was just there in the back of my mind as something that I needed to be aware of. The loss of so many women in our family from cancer was always the elephant in the room, so to speak. Everyone held their metaphorical breaths and hoped that cancer did not appear in our family again, and we all got on with living our lives as best we could without the presence of these precious family members. In the mid-80s, I went off and trained to become a registered nurse, and with that knowledge in hand, I sat bolt upright and took notice when the BRCA genes and their role in cancer genesis were discovered in the mid-90s. By that stage, I was married with a couple of young children of my own, and there was nothing that could be done at that stage. So yet again, I got on with life, raising my family. In 2001, aged 35, I discovered a small breast lump. My heart sank and the fears of cancer were very real. Fortunately, that lump proved to be benign, but as a result, our family's cancer history came to the attention of my breast surgeon, and with his encouragement, I attended a Familial Cancer Centre to seek advice regarding the possibility of genetic testing, based purely on family history. Before attending that appointment, I had to fill in a family tree of both sides of my family that identified any cancers that any family member had had. I rang up relatives and I chatted at length with my parents to be sure that I was presenting information that was accurate. At the appointment, the genetic counsellor looked at the information that I had brought and identified our family as high risk for carrying a cancer-causing genetic mutation. But she also advised me that genetic testing at that stage was not possible, as testing could only be offered to a family member who had cancer. And as I said earlier, all family members had died. In 2001, the science of such genetic mutations was still too new. And as I was told, it would have been like looking for a needle in a haystack. I, along with other members of our family, was advised to undergo high-risk surveillance of my breasts. There was no specific recommendation for ovarian cancer screening, however, beyond the suggestion that risk for ovarian cancer did not begin to rise until the mid-40s. 12 years slid by, along with yearly mammograms and breast ultrasounds, as well as several fortunately benign breast biopsies. In late 2013, aged 47, I presented, again with the encouragement of my breast specialist, to the same genetic counselling service for some updated advice. Part of my motivation was my two daughters. They were growing up and leaving home, and I did not know what to tell them regarding their own risks. I wanted some insights so that I could advise them if there was anything that they needed to do. At that appointment, I was told that testing could now be done for our family, that over the 12 years since my first appointment, a database of known mutations had been built up, and that our genetic structure could be compared to that database to identify any abnormalities. The genetic counsellor wanted to test my dad first instead of me, though, as he was the blood relative closest to the women who had been affected by cancer, and there was a higher chance of finding something in him if something did exist. After waiting 3 long months for an appointment, in early 2014, my dad was the first in our family to undergo genetic testing, and they tested 4 of Dad's genes to look for a fault. I am incredibly grateful to my dad for so readily agreeing to do that testing, as ultimately it has made an enormous difference to our family. We waited 2 months for Dad's results to come back, and they showed that he had tested positive for a pathogenic fault on his BRCA1 gene that did put carriers at increased risk of breast and ovarian cancer. On the same day that we got Dad's results back, I underwent my own genetic testing. When my results came back a further 2 months later, I learned that I had inherited that BRCA1 fault from him. My husband was with me when we received the results, and I recall saying to him, well, that's not surprising. Although there was a 50% chance that I had not inherited the fault from Dad, testing positive just reinforced all that I had ever felt, that this was an important issue for me. While waiting over those months for the rather time-consuming process of testing to unfold, I had given a lot of thought to what I would do if my results came back positive, about how I would manage the risk and how I would move forward with that knowledge. By the time I received my positive result, I was 48, so I immediately organised an appointment with a specialist gynecologic oncologist to arrange surgery to decrease my risk of getting ovarian cancer. My ovaries and associated anatomy had served their purpose well, but I felt that they represented an unacceptable risk to me, even though I was in excellent health and precautionary CA125 blood tests and an ultrasound were perfectly normal. Just 8 weeks after learning of my BRCA positive status, I underwent a risk-reducing bilateral salpingo-oophorectomy and hysterectomy. 36 hours after that surgery, just when I was expecting to be discharged from hospital, the surgeon came into my room, sat on my hospital bed, and told me that a small tumour had been identified on pathology. I already had ovarian cancer. That conversation is firmly embedded in my memory. I recall a weird sense of complete disbelief. There I was thinking that I had been going to decrease my cancer risk when I actually already had it. I still look back on that day with a strange sense of disconnect, like it was someone else's experience or a movie that I had been watching. As I'm sure many of you can relate to, things moved quickly from that point. Appointments with oncologists and oncology nurses, PET scans, loads and loads of pamphlets to read, many tears, endless questions with no answers, overwhelming fears, and 6 rounds of carboplatin paclitaxel chemotherapy. When all that was finished, I tried as best I could to settle back into life after cancer treatment. I recall saying to my husband during chemo that I just wanted to get it over and done with and get my life back. What I had failed to appreciate was that life was not going to be the same as it was before. Of course, I was still me, but it was like I'd been tossed into a parallel universe where things were mostly the same, but not exactly as they were before. That genetic test was the one thing, the only thing that enabled me to get an early cancer diagnosis. Everyone said that I had been lucky to get such an early diagnosis, that I should be fine and the chances of cancer returning were low. The odds were stacked in my favour that we had got to the cancer in time before it had spread. On one hand, I did feel fortunate, but on the other hand, I felt anything but. Over the next 5 years, I slowly settled into the new me. I relished my family, I set goals to look forward to, and I appreciated all that was good in life. At my 5-year follow-up appointment, I was told yet again that I had been fortunate and that after 5 years, I would have to be unlucky for it to come back. 6 months later, in January of 2020, the first little red flag was raised when my routine CA125 follow-up tests were up just marginally, still well in the normal range, but just marginally higher than they had been in the previous 5 years. We entered a more active monitoring phase again over the next few months, but in August 2020, exactly 6 years to the day after my initial diagnosis, came confirmation that the cancer had returned. What followed was more tears, more unanswerable questions, and more chemo. While genetic testing ultimately has not prevented me from getting an ovarian cancer diagnosis, it has enabled other family members to undergo testing and become aware of their risks. I take comfort from that knowledge that my experiences have been of benefit to other members of my family. My siblings, children, 2 surviving aunts, my cousins and their children, my nieces and nephews have been or are going through the processes of being genetically tested. Those who test negative can move forward with their lives free of the fear that comes with living in a high-risk family. And hopefully those who have tested positive will now be able to avoid a cancer diagnosis. Knowing about that pesky mutation has given us all an opportunity to deal with it, to manage it, and to take some sort of control over our own health. No more holding of our collective breaths and waiting blindly for the cancer card to deal its hand. I have also undergone bilateral prophylactic mastectomies and reconstruction to deal with my breast cancer risk. And while I am now facing the confronting reality of living with ovarian cancer for the rest of my life, knowing about the mutation has also given me the option of being able to access drug therapies that have been shown to be a bit of a game changer in the BRCA setting. So here is hoping that the olaparib tablets I now take can hold my cancer at bay for some time to come. Of course, the thought of undergoing genetic testing can be daunting, while the actual process of attending a familial cancer centre, undergoing the genetic counselling session, and having the blood test were all quite straightforward. I will be the first to admit that I was extremely nervous waiting for Dad's test results to come back. I was aware that finding out information that I had pushed hard for had ramifications for the whole family. I will also be the first to admit that after I found out that I did carry the BRCA1 mutation, that I was uncertain, nervous and scared of the surgeries that I had decided I needed to do. Also, I wasn't sure how other members of my family might view my decisions, but I need not have been concerned. Every member of my family has been very supportive and grateful, I suppose, to finally have some understandings of why so many members of our family have had cancer. The only regret that I have through this whole journey is that time slipped by and I did not return to the Familial Cancer Centre earlier for updated advice that second time. The course of my ovarian cancer might have changed if I had, but of course regrets serve no good purpose to anybody, so I do the only thing that I can do, and that is move forward with life as best I can. The science of genetics is very much an evolving field, and I think it is important that we all continue to monitor its progress. The knowledge base is continually changing, and what might not seem applicable today might well be applicable in the years ahead. We all need to advocate for ourselves and be as informed as we can be for our own health. I continue to try and find more distant blood relatives to inform them of the possibility that they might carry a genetic fault. Through this research, I have identified 3 of my grandmother's cousins who died of breast cancer in their 40s and quite probably carried the same mutation. I have been able to track down and contact a few distant relatives, but other family branches remain elusive. I was very nervous about contacting them and telling them of their genetic fault. I was a complete stranger to them, and I felt like I was lobbing information into their lives that they may not have wanted. But I felt I had a responsibility to bring this awareness to these people. Generally speaking, they have been very receptive to the information that I have shared. They have been aware of cancer in their families, so it was not a total surprise to them. But how anyone chooses to proceed with the knowledge is theirs, and the decisions that they make are theirs. But I am an enthusiastic supporter of anyone proceeding with testing. I try to find these relatives for a couple of reasons. The first is that I think of my aunts, my grandmother and my great-grandmother, as well as my grandmother's cousins, and I ask myself what they would wish me to do. And every time I ask myself that question, I think that they would encourage me to make the most of an opportunity that they never had. Secondly, I would like to think that if one of the other branches of the family knew about this mutation, that they would have tried to contact our branch to share the knowledge with us. There are 2 quite famous quotes that also keep me moving forward and encouraging others to consider looking at the option of genetic testing. One is a quote used by a number of influential people, including John F. Kennedy, and it says, "It is better to light the candle than to curse in the darkness." The light of knowledge has the potential to give individuals options instead of just stumbling along, not being aware of the risks that they might carry. The other quote comes from Mary King, who was instrumental in identifying the BRCA genes and recognising their role in cancer. She said that to identify a woman as a carrier of a genetic fault only after she develops cancer is a failure of cancer prevention. While I have not avoided a cancer diagnosis, there is no doubt that identifying the genetic fault changed the course of cancer for me and certainly for my extended family. I'm sure by now you can see that I'm quite the advocate for genetic testing. My experiences have clearly shaped my attitude and approach, and as a result, I am keen to encourage anyone who might have such a genetic predisposition for cancers to try and find out, not only for themselves, but for their families as well. Thank you, Vanessa. Thanks, Vanessa.
Sorry. Thank you so much, Christine, for giving us an insight into your journey and how important genetic testing has been for you. And I know everyone on this webinar will really appreciate you being so open and willing to share your story. I do realise we have gone over time. I do apologise, but it's been just such valuable information that the speakers have shared. So we'll just go with one question. This is for Christine. How have you managed to find your relatives that you did not know?
Good question. I have a very extensive tree on ancestry.com. So I have purchased death certificates for distant relatives, and through those I've managed to basically trace down. Social media has been great. Yeah, but most of it's been through ancestry.com, creating an enormous family tree.
Fantastic. Thank you again, Christine, for giving up your time. We really, really appreciate it. And also to our other speakers, Associate Professor Marion Harris and Associate Professor Yoland Antill, thank you so much for all the information that you've shared and for giving up your time this evening. So thank you everyone for being on the webinar. We really hope that you found it valuable. The recording of this webinar will be posted on our website over the coming weeks, and you will receive an email with a link to the recording in the next few days. In a moment, you will be redirected to an evaluation form. If you could just please take a moment to fill that in, because your feedback is extremely important to us and will help us to plan and develop future webinars. If you have any other questions that you would like addressed, please don't hesitate to contact our information and support line on 1300 660 334. This is a very challenging time for everyone, and we know that some of you may feel that you need that extra support, so please don't hesitate to contact us. Thank you again, everyone, for being on this webinar, and we hope to see you for our next webinar in a few months' time. Enjoy your evening. Goodbye.